Great, thanks for joining everybody. Welcome to our Digital Health Week webinar. Just want to note at the top that the discussion is going to be recorded today. So if you are not comfortable with that, we absolutely understand. Feel free to drop off the recording and we'll certainly share it out afterwards. Also just want to note that the chat and the Q&A will be active and monitored throughout the session. So if you have questions or you want to talk about anything further, please just feel free to pop a question in the chat and we will be sure to answer it. Wonderful. So let's get started. So I'm Vicki Ward from Digital Medic. We are an initiative from Stanford Center for Health Education. And I am here today with some of my colleagues from One-to-One and from Lwala. Today we're going to be talking about how we create digital learning to complement in-person training for community health workers. So just to sort of introduce us briefly, Digital Medic is an organization that envisions a world where all communities have access to engaging, evidence-based, and actionable health information. And so as part of that, we really aim to support community health workers. We know that community health workers provide much of the most important maternal and child health care worldwide, and that studies show that millions of annual deaths could be prevented by the care that trained and supported community health workers can provide. So we are primarily committed to reaching health workers in their communities with evidence-based, timely, and understandable health information. So before we get started on how we do that, and just briefly to introduce our speakers today. So I'm Victoria Ward. I'm a pediatrician and a clinical associate professor of pediatrics at Stanford School of Medicine. And I serve as the medical director for Digital Medic. And let me turn it over to Monika to introduce herself.
Hi, everyone. My name is Monika Deschodt, and I'm a learning experience designer with Digital Medic. I am the project lead for this specific project that we're going to chat about today. I'll turn it over to Emma.
Thank you. Good evening, everyone. My name is Emma Chademana. I'm the head of programs at One-to-One Africa. And One-to-One Africa is a community health organization providing health services in last mile rural communities in South Africa, with a particular focus on maternal child health, early childhood development, adolescent health, and men's health. And I will hand over to Hellen. Thank you.
Sorry, good evening, good morning, everyone. My name is Hellen. I'm Director of Programs at Lwala Community Alliance. And Lwala is a community-led organization where we are engaging community committees, community health workers, and government health centers to deliver a high-quality health services for all. We ensure that we have paid, trained, and supervised, and also digitally empowered community health workers so that they are able to extend their services to household level. And through our model and research, our model has proved to be significant in reduction of infant and mortality deaths, as well as increase of other services, including contraceptive use. Thank you, and back to you.
Wonderful. Thanks, everyone. And thanks to those in the chat introducing themselves. It's wonderful to have everybody know each other here so we can have a rich discussion. So today our goal is to talk about our course development process, how we create digital health courses as a team. We'll be talking about each step of that process. So talking about how we create and implement that digital learning solution to support community health workers. So we'll kick off by talking about the need and how do we figure out what the most important problem or issue is that we should prioritize to create a learning solution for. So how did this course or idea come about? our stakeholders or our partners on the project are really sort of key to helping us think through what they need. And part of our job is really to just listen and find out what the needs are and then respond to those in a way that is effective for them. And so those stakeholder discussions are most important for content development. And we are really focused on creating focus group discussions to make sure that we're listening well. And then we do sort of an analysis and design process. So how do we come up with the learning solution? And what is the sort of iterative and learning-centered approach for creation of this project? Next, we do solution development, and a lot of that is sort of creating the content and then doing user testing. So making sure that the content that's created really resonates with learners, that they find it helpful, and that we communicate the learning objectives well. And then in terms of implementation and distribution, how our partners are really learning together and implementing that solution and finding out if it's working for their community health workers. And then most importantly, we always think about monitoring and evaluation. So making sure that the content is successful, it's having the intended impacts of learning and changes in knowledge, attitudes, behaviors, and ultimately health outcomes. Next slide, Monika. So now we'll talk about how we came up with the idea in the first place. How do we sort of think through what community health workers are asking for, what they would be helpful for them in terms of training. And I think in the context of this solution, we were really thinking through what are the primary killers of children worldwide. And so we know that pneumonia, diarrhea, and malaria are responsible for almost a third of global deaths among children of age 5 or younger. And I think that is both compelling and important, but also we recognize that community health workers are really sort of carrying the weight of responding to and caring for children. And so that initiated a discussion with some of our partners about how can we train community health workers to respond. But certainly the most important people to answer those questions about what is needed and what community health workers would benefit from are our collaborators. So Emma, I'll turn it over to you to just talk about the need that you've seen in the community and what you're hearing from your community health workers about what would be helpful in terms of training.
Great, thanks, Victoria. So you've rightly pointed out the causes of child mortality and the issues. So for us working in the rural Eastern Cape, we have diarrhea, pneumonia, and malnutrition being the leading causes of child deaths in the province. And for example, in South Africa, 31% of the child deaths are attributed to severe acute malnutrition, which, if identified early, malnutrition can be effectively managed with children being rehabilitated. And now CHWs are the first point of contact for many of these children, providing support which includes prevention, treatment, and care. Thus, for us as One-to-One Africa, it's important that our CHWs and our mentor mothers are capacitated in terms of knowledge and skills to identify, manage, and appropriately refer such cases. And also one of the recommendations put forth by the Committee on Morbidity and Mortality in Children in South Africa is to strengthen the capacity of community health workers to address common childhood illnesses. For example, through courses and training. And for us, although we have a refresher training scheduled throughout the year, they often tend to be resource intensive with distances and terrain challenges to overcome. Thus, there was this need for our mentor mothers and community health workers to have readily accessible content, enabling them to learn, refresh their knowledge, and stay well informed in between the trainings. I think that was really the need for us at the beginning. Yeah.
Yeah, in addition, I would say that for the curriculum in Kenya, the curriculum for community health workers was in existence. And also that at the same time we were doing this, the curriculum had just been reviewed. And one thing we had picked from previous training on ICCM was the aspect of the score of the post test wasn't so high. And we got to appreciate that ICCM is one of the courses that would take time for the community health workers to learn. And now the digitized material, being able to see how practical it is to assess a child or to conduct a test and all the practical aspect sort of improved the learning capability and making the skills easier to learn in the process. Thanks, Victoria.
Thanks so much, Emma and Helen. And just to say that I think as we talk with partners like Emma and Helen, we hear sort of similar themes about ICCM training and what community health workers are asking for with regard to evaluating children that are sick. And so hearing that and knowing that there's sort of coalescence around those needs, our goal really at Digital Medic is to use resources as efficiently as possible to respond to that effectively and to create content that will be useful. So in terms of doing that, I'll turn it over to Monika to talk about sort of the next steps of how we start to develop the content and build it for that purpose.
Thank you so much, Vicky. So obviously we can't do these projects on our own. So for this specific project, we were funded by Alma Philanthropies, as well as the Stanford Center for Health Education. And we worked very closely with an advisory group of community health workers, as well as with our 3 key partners on this project. So One-to-One Africa, Lwala Community Alliance, and Philani Maternal Child Health and Nutrition Trust. So how did we come up with this design of this course, and why did we decide that digital was the way to go? So we always start projects by doing an extensive analysis. And for this specific project, it involved analyzing our learners, who our community health workers or CHWs were. What were their learning materials that they currently had access to, as well as what was the learning environment that they were exposed to. We started this process by speaking to our stakeholders or our partners on this project to understand from them what were their high need health areas, what did their CHWs need, as well as who were the community health workers. Then we also did an in-depth content analysis. So this was looking at our current partners' curriculums, as well as best practice curriculums like WHO and UNICEF, and then also looking at the curriculums of the ministries of health. So that would be from South Africa and Kenya. And then most importantly were discussions with our learners. So having these online focus group discussions to really understand what were our learners' learning preferences and what were their learning needs. And then once we had developed a prototype to test, to once again connect with our community health workers and then understand, was this prototype resonating with them? What did they think of the visual style? What was the pitch of the language? Would they find these types of assets useful? So putting all of this analysis together in terms of a design. And what we came up with was a digital learning solution and a digital course aimed at teaching community health workers to care for sick children in the community. So I'm going to hand over to Sarah, the narrator on our course, and ask her just to give you a bit of a high-level outline on what this whole course is about and what the aim is.
As a community health worker, you may see children with a cough, fever, diarrhea, or other symptoms. These could be caused by illnesses such as malaria, pneumonia, HIV, or tuberculosis. Without proper care, these illnesses may threaten the life of that child. But by taking the correct steps, you can help to change this. Join me and my colleague John as we teach you how to identify the early signs and symptoms of common childhood illnesses for children between 2 months and 5 years of age. Learn how to decide if a child can be cared for at home or if the child needs to be referred to a health facility for urgent care.
Thank you, Sarah. She still wants to continue. So basically the course structure is around common signs and symptoms of illness that community health workers may come across in a child. And each of these learning modules contains a whole lot of learning elements, such as assessments, videos, which contain the learning content, exercises that learners can go through, as well as job aids, which are on-the-job tools to support learners when they're in the field. The aim of this course is mainly to supplement current community health worker training. And as we designed and developed the content for this course, all the reviews were done by subject matter experts and medical experts from the Stanford Center for Health Education, as well as our 3 partners from One-to-One, Lwala, and Philani. The great thing about this course is that the content is accessible on any device at any time, either online or offline. So I also wanted to just give you a little snippet of one of the videos, just so that you can get a sense of what it entails. And this specific video is around how to identify fast breathing in a child. And I also wanted to just draw your attention to the job aid. So the job aid is usually a 1 to 2 pager summary of what is covered in the video. And learners can access this as a refresher when they're in the field. They can access it digitally, or they can also print it out. So I'm just going to play the short snippet for you.
Look at how the chest expands, or gets larger and moves up when the child breathes air in. Then the chest contracts, or gets smaller and moves down when the child breathes air out. You will be counting the number of times the chest expands when the child breathes air in 1 minute or 60 seconds. To time 60 seconds, you can use a watch or clock with a second hand, a respiratory timer or a timer. Make sure that you put the timing device where you can see it and the child's breathing. If using a watch or clock, start when the second hand reaches the number 12 or 6, so it is easier to remember. If using a digital device, the second number should be 00. When your timing device is ready, start counting the number of times the child breathes in and their chest expands for 60 seconds. If the child moves or starts to cry, stop counting. Wait until the child is calm and start counting for 60 seconds again.
Great. Thank you, John. John is our other narrator on some of the videos. So what we also wanted to do is make sure that when we had developed a full module with all the different learning assets, to check in with our learners again and make sure that whatever we had developed was actually meeting their learning needs. So we conducted user testing with volunteer community health workers from our partner organizations, which consisted of one-on-one interviews with our learners. And the feedback that we received was really positive. They found that the content was really concise and easy to go through. They also found that it was a good alignment to their current training, and also a good substitute for in-person refresher training. In addition to being well aligned to what they were currently learning, they also found that it just gave them a little bit more. So they learned a couple of additional things in the training. And also they gave us feedback around the usefulness of these digital assets, and found that it would be really useful in their day-to-day work. They also highlighted a couple of benefits or advantages of digital learning for them specifically. So they said that it was really fast, much faster than in-person training, which was a couple of days. They also found it really valuable that they could repeat the training. So if they wanted a refresher or they forgot something, they could easily access it and go through it again. The information was standardized. So often in-person training, you have different facilitators who answer questions slightly differently, whereas this content is always standard and you'll always get the same message whenever you view it. They also appreciated the visual aspects, and interestingly enough, they found that through the videos, they could actually learn practical skills. One of our community health workers said, it's easy learning using pictures and videos, which is very much aligned to our philosophy around learning and making learning engaging and accessible. So our content is openly accessible under our Creative Commons No Derivatives license, which means that you're able to freely share it without modifying it. You can also access our content on any of our channels, such as our website, our mobile app, or our YouTube channel. We launched the key components or the key modules of our course in late September. And by the end of October, we already had over 1,000 downloads from our website, 600 plus enrollments on our app, and over 6,500 views on our YouTube channel. And a lot of this was also due to our partner implementation, which has also started and is currently rolling out. I just wanted to take this opportunity to connect with our partners at this stage and find out a little bit more around how they're implementing and how this is working for them. So I'd like to start with you, Hellen. You've integrated this course into your face-to-face ICCM or integrated community case management training. You did this last month. Please, can you share with us, how this worked and how your learners and facilitators have reacted to this digital integration?
Thank you, Monika. So what we did before we started the training, we had a meeting with the facilitators where we were able to disseminate the content and with step-to-step on how to download and how to use the videos and the rest of the content. And we did a sneak peek because this was a one-day session. We did a sneak peek on how the content can be integrated. And we still followed the ICCM guideline in terms of number of participants per class, ratio of facilitators to participants and all. And we were able to have the mixed sessions where some videos would play, then the class would discuss. And if there's any questions or any content that was left out that wasn't covered in the video, it was part of the discussion before we could move to the next topic. And this was done every day for the 5-day training on ICCM. Some of the feedback we got is more or less the same as we had expected, because these had also been collected during the content creation pieces, and that the learners were more confident in learning the content. They were excited, and learning was more easier than going through the hard copy content or the classroom content than now going to practical. In our curriculum, 2 days are for practicals, where now the CHWs are working with the real patients, so they are attached to a facility. Comparing the previous classes we had handled and this first class we did, the CHWs were more confident in assessing the children because now they had seen practically, say, how a child who's not breathing normal should breathe, how the counts are done and all that. So they were more confident in dealing with patients, where previously they could be intimidated and you needed to do the session more than 1 or 2 clients before the CHW get it right. The other bit is that the content was shared on the first day of training. So some of the CHW, when they went home in the evening after the first day, they were able to watch more than what they were supposed to cover the following day. And so their activeness in class and their participation was quite high compared to previous classes that we had done. So this was so exciting, both for the facilitators and even the learners. And we were able to train 969 CHW on the same. Yeah, thank you. And back to you, Monika.
Thank you. That's fantastic. Congratulations, Hellen, to you and your team. I just wanted to also ask, what were your reasons for moving towards like a blended or integrating digital into your normal training?
There are several, I can say 2 reasons. First, given that our trainings are quite monitored from the government end, and we are working with government on this, we needed to orient them to the content before they could accept it fully. So working with them on the digital end, they are still confident that we are following the curriculum so that we could get that buy-in. But other than that, was to ensure that we are covering all the content, both the digital content and also the ensuring that this is aligned to the existing curriculum, and ensuring that if there is any gap in between is covered, and also to build the confidence of the system for the digital content.
Fantastic.
Above the other advantages that I had mentioned, that now digital was easier. And also to note is that our CHWs are all digitized. So getting the content into their phones was quite easy for them, and they were able to go through it. Yeah.
Fantastic. Thank you, Hellen. And just what value do you think that digital learning can add to your future trainings? Is this something that your organization is looking at pursuing in the future or continuing? Is this a pilot?
Yeah, so we are seeing this as a great opportunity. I don't think we will go back to doing the trainings the way we had done them before, because the outcomes are great. The post-test was much better performed this time round. The CHW are excited with the content. So we are going to remain having these. The other bit, I think this is going to help us so much, is because for ICCM, because of the number of skills the CHW needed to learn, there was a lot of refresher. We could do a refresher training every year for all the CHWs. And in between, you could still have to do small group sessions to visit areas where you'll find that the CHWs are not so competent. I think the cost and the time invested to that is now not going to be there. Because the CHW now will be having content every time they need it. They can always refer to it if they are doubting, and there'll be minimal revisit in terms of mentorship. And even at that, you do not need so much tools, either the manuals or all that. And so we are expecting that even the small group sessions, which can be done during their reviews, they will be having this content. So the other thing we are hoping for is that we can package this for national adoption, given that we have piloted this in one county and we are seeing it working. So advocacy on the content and packaging it for national adoption is one thing we see as an opportunity. The other bit is also, can we be able to package all the community health worker content into a digitized version so that we can reduce all the costs, we can have learning happening faster, and we can have content more accessible to CHWs in a more fun way or an interesting way that they would enjoy learning, and they will be more confident in their work, and they can always refer on their own with minimum support. Thank you, Monika.
Wonderful. Thank you, Helen. Big plans ahead. It's great to hear that. Emma, you're implementing the digital course at One-to-One Africa in a slightly different way. Would you be able to tell us a bit more about that and how it's working?
Yes, sure, Monika. So we have taken a slightly different approach. We are implementing it in a cascading stepwise manner. So we've started with the managers and the supervisors who are doing the self-paced course. And then we're doing our mentor mothers and the community health workers. Then lastly, the third group is the other community care workers that are for the ECD and the male engagement and men's health programs and adolescent health. And then we're also implementing it using a hybrid approach. So it's a combination of blended learning, so self-paced, the digital one, where all our community health workers and team have downloaded the app on their phones, because we use mHealth in our work. So everybody, all the staff members have mobile devices, so they've all downloaded the app. And then we are also using it, the course content, as a supplement during the in-person refresher trainings, similar to what Hellen and Lwala are doing. So this is in our upcoming refresher trainings. We'll use some of the videos and the content there and the job aids as well in the in-person training. Then thirdly, we are also using the content as knowledge skills as a topic for our monthly meetings. So every month when we select a topic, we use one module that we unpack and discuss during the section where we do our knowledge skills discussion.
Fantastic. And is digital learning new to your community health workers? And if so, how have they responded to, these digital elements that you've integrated into your training?
Yes, it certainly is new. Actually having a whole course, and I think the first encounter was when the community advisory group for this course. So they were the first group of mentor mothers and community health workers who took the digital learning course in the pilot, and it's had great feedback, positive feedback from the community health workers and mentor mothers. I think there was always this need, the need that we talked about at the beginning, of always needing content, needing to refresh yourself when you're at home or in the field, without having to wait for the refresher training that happens after 6 months. And because it's rural, we work in deep rural areas, it's not always easily accessible. So teams are not always easily able to come together to discuss and to have, whenever they have questions, they're not always able to meet in person. So having this course and the content readily available and also accessible offline has actually been a game changer for our mentor mothers and community health workers.
Wonderful. Thank you, Emma. And what do you see as the role of digital training for your organization going forward? Is it something that you wanting to integrate a lot more, or are you starting with this course? What are your thoughts around that?
Wow, we're actually trying to document and get the learnings from this childhood illnesses course and the experiences of our community health workers and mentor mothers. and explore also implementing other digital learning platforms and courses for our other teams as well. For example, early childhood development. Then secondly, we also would like to pilot this digital learning course in our province, in the rural Eastern Cape, with our community health workers, as well as the DOH government community health workers. And if it's successful, which I believe it will be, we would like to also explore piloting it, expanding and scaling it across the country through our partnership with Department of Health, as we are training and implementing partner of Department of Health.
Wonderful, thank you. And exciting times ahead. So through this whole course development process and implementation, we have come across a couple of challenges along the way, but also have, through this, identified possible solutions to these challenges and also opportunities and possible next steps. So I just wanted to share with you a couple of things that we came across. So some of the challenges around a lack of digital literacy and tech difficulties in terms of navigating on the app were raised. There is thinking around possibly doing digital literacy training or upskilling digital champions. So upskilling people in organizations to be that first line of support for learners in case they have any questions or they're struggling with the app. And obviously this depends on organizations. It depends on where organizations and CHWs are in terms of their digital rollout. And then also the recommendation is to really implement in a gradual stage and structured approach. So this is especially if community health workers or learners haven't had a lot of exposure to digital devices or digital learning. It's really useful to start by familiarizing learners with digital content slowly and using specific points in training or day-to-day operations to gradually bring in these assets. So for example, as you mentioned, Emma, sharing a video and then having a discussion in person around learnings or, you know, any questions they may have, or also using videos as part of in-person training as you're currently doing, Hellen. Also, what we would like to do is create step-by-step videos to help learners access and install and update our Digital Medic app, as well as navigate through the learning content. So provide those additional resources for learners. And then the other challenge, which we come across fairly often, unfortunately, is lack of internet connectivity, smartphones, and data. And I'm sure a lot of you listening have also come across these types of challenges. We are always looking at exploring possible solutions to address or to solve these challenges, not always easy. Our Digital Medic app does have offline capabilities, so learners can download videos when they're in a Wi-Fi area and then view digital assets offline. We also always focused on creating as smaller files that we can so that it uses less space on devices and less data. And then also in some of our discussions, learners voiced the request that they wanted to have some face-to-face connection. They wanted the ability to ask questions. So a fully digital solution, they weren't comfortable with that. And as we've heard from both of our partners now, that they are using a more blended or hybrid approach. So it's basically getting the best of both worlds. So having that digital component for refresher purposes, for in-time learning, but also having the ability to connect with someone, to ask questions, and to, you know, practice the skills with other learners. Again, I just wanted to ask both Emma and Hellen, have you experienced similar challenges? Are there any other challenges that you've experienced along the way, and also opportunities or lessons learned that you would like to share with us?
If I may start, I think for the digital aspect, it wasn't a challenge for us because the CHWs that we were training had already been trained and were using the digital tools. So using the digital system wasn't a challenge, though we could help them with downloading for those who are getting challenges with downloading. And then for connectivity, I think we were aware of this prior to the training. And so what we did is we worked with them to download all the content from day one. And some of this, the sites where there were issues with connectivity, somebody would do tethering, and we had taken that into consideration, and so we were able to support the teams in terms of having the content offline instead of having it online, because that could have brought a challenge. In terms of opportunities, I think these made, for us, we looked at this and said it's a good opportunity, and probably what we are talking about, integrating these to the national curriculum. The good thing is that the Kenyan curriculum had just been reviewed when we were doing this. And so aligning the content and working with the Digital Medic and the other partners to ensure that we are not off what the ministry expects us to do. And so all the content were relevant. And so we see that as an opportunity to scale. And given the timing as well, that we had a good timing right now. In Kenya, digitization of CHW is a national intention, which is going on right now. And we are also seeing that as an extra opportunity, because even for areas we will not be working, it will still be feasible because there's the process of digitizing all CHWs. Thank you, and back to you.
Thanks, Helen. I just wanted to add that although we aligned the course development and the materials to Kenyan and South African ministries of health and training materials, the aim was also to ensure that this content was scalable more broadly, so applicable to other countries, whether they're implementing ICCM or not, as well as to other organizations who are training community health workers, because childhood illnesses are everywhere and the principles remain the same. Emma, any thoughts from your side?
Yes, I think in terms of challenges for us, for our team, I think it was connectivity, similar to what Hellen experienced. It's also connectivity when downloading. But once you find network, then the downloading is completed and you can actually use the app offline. You don't need internet. So I think that was a plus. So it was a really minor challenge that we've experienced. And then in terms of opportunities, for us, through our partnership, as I mentioned before, our partnership with the Department of Health, we see that there's an opportunity to extend this course to government community health workers and incorporate it into the bigger and broader CHW training, especially right now as South Africa is moving towards mHealth, mobile health for community health workers. So I think that's really a great opportunity. The government community health workers in South Africa, most of them in most provinces, if not all, now have mobile devices. And that's just a great opportunity then to also have that course available on their devices.
Wonderful, thank you.
To mention, Monica, just being grateful that the content was made quite light. Sometimes the videos can be heavy or the content can be heavy to download. but the way the content was created was light enough to not use a lot of bandwidth in downloading. And there was a low cost, I would say, for bundles, for having that access to the content.
Absolutely. And that's always one of our focus points, is to try and make these as small as possible, so that they are downloadable. And often our learners say, we want more live footage. We want to see real people. And as much as we'd want to create videos like that, there's also the consideration around file size. So when you include those types of aspects, you also get bigger videos. So we also try and balance the needs of all our learners. I'd like to now just hand over to Vicky, just to take us through how we see evaluating this solution sometime in the future. Over to you, Vicky.
Thanks, Monika, and thanks so much, Helen and Emma. It's really fun to hear sort of how you're thinking about the course and how your CHWs are experiencing the course. I think, as I had mentioned earlier, evaluation is sort of part and parcel of everything that we do. So all of our courses are co-created, both in terms of what CHWs are asking for and also what their experience of the course is as it's created. So part of the course design process is having those sort of rapid iterative feedback sessions where we're getting input about how CHWs see and experience the course and what they would like to be different, and trying to be responsive as possible to all the feedback and input that we receive. So that's sort of looped into the course design process. And then as CHWs are taking the course and using it, how are they using it? Are they using it on their phones as they're going out to see patients? If they're going to see a child with a fever, are they pulling up that course module on fever and sort of refreshing in that way? Or are they using it primarily in the blended learning training approach? So that information is helpful for us to know how to sort of think about the evaluation of the course. The sort of most proximal way in which we evaluate impact is on knowledge, attitudes, and practices, or intended practices. And so each one of the modules are associated with assessment questions, both about sort of the knowledge gains that are aimed toward in the course modules, and then also about their practices. So are they learning about counting respirations? Are they thinking about fever in the same way that's aligned with the ICCM training recommendations? Knowing whether those knowledge gains or those changes in practices are occurring are really important in understanding, does this course achieve those learning objectives that it set out to do? And then sort of the hope and the ultimate purpose for this course is really to benefit health outcomes. So are the children who need to be referred being referred? Are the children who may have otherwise gotten sicker at home being intervened upon in a way that's useful for their health ultimately? How is this eventually benefiting the health of children for the purposes that it was created? And that, of course, as we all know, is both most important and also most expensive. But we are thinking creatively about how to leverage the data that's already being collected by CHWs to be able to understand those health benefits. So for instance, Helen's colleagues at Lwala use the CHWs system. So any of our attendees who are from Kenya will know the government data collection system of CHWs collects a lot of the information that we intend to benefit. So a lot of the information around the vital signs or the current health status of the children the CHWs are visiting. And how can we leverage that data that's will be collected for us, would be transferred in a de-identified way, to really understand whether this curriculum ultimately benefits health outcomes. That is something that we are currently fundraising for, but is really our hope to understand, does the curriculum result in health benefit? So I think the course is being evaluated in many different ways, but ultimately what we're hopeful for are the things that Emma and Hellen mentioned, which is really CHWs feel better trained, they feel more confident, they feel supported in their work as they go out to take care of children who might be sick. So I think we are always keen to continue that process, but really understanding impact is so important. So now let's move on to some of the questions. It's really fun to see some of those questions coming through the chat. And we'd also love to hear the attendees or others' thoughts, ideas, experiences with course development or implementation, how you're using blended approaches to ultimately benefit health. And excited to just sort of have more of a conversation in our last 10 minutes. Kat, are you able to pull up any of the sort of questions either in order, whatever you think is most valuable?
Absolutely. Thank you so much to everyone submitting questions, and please keep them coming. Some have already been answered, but here is one from Jenny. How are updates managed? Is it relatively easy to add or edit modules to reflect new guidelines, content, etc.?
Yeah, I can take that if it's helpful, Monika. So updates can be difficult. I think one of the reasons that we use an animated approach is that we can use voiceover that is much easier to change than full video content. And so there's both the technical aspects of the sort of app updates and those technical bugs, which thankfully the SCHE team can be helpful for. But for content updates, for instance, if there was a new WHO update to the ICCM training recommendations, it's easier for us to splice in those changes to the audio when we have the audio and the animated video separated in that way. So in sort of as we studied whether we use animation versus live video, that was one of the values of using animation. Monika, any other thoughts about that?
Also that we try not to go into those types of details that could possibly change very often, and rely on organizations to kind of manage those aspects of, for example, treatment or medication or anything like that, that may change fairly regularly according to like regulations or policies. So we try and just like give a foundational knowledge, and then allow partners to kind of supplement the learning and supplement the details with their specific requirements, because also often these things are country specific, so we cannot cover every single detail for every single community health worker out there. So we try and just like give base knowledge, and then rely on that supplementation.
Great, thank you both. Emma answered from her perspective in the chat already, but wondering if we want to talk about this some more. Wendy asked, was language ever an issue, or has this been produced in local languages as well? We touched on that a little bit, but not sure if anyone has more detail to add.
Yeah, we generally try to have those conversations early about what are the most important local languages. So the majority of our content is then translated. We use a translation service for that. And again, that audio voiceover is really helpful for that purpose. So for our Lwala content, we typically use Duo. I think it depends on the partner, and as we think about scale and sustainability, we are always keen to make sure that we can translate content in as many languages as possible.
Thanks, Vicky.
If I may add, is that the English narration was made to also be as simple as possible For Kenya, we use English as a mode of, like most of our content is in English already. So in training of CHWs, we could still use English and do some translation for areas that are not understandable. But that the narration, I think when we were creating the content, ensuring that the speaker is speaking slowly and using very simple English for basic English skills understanding. Thanks.
Great. Thank you so much. One question that just came in from Piwe. Have a question about the pace of scaling and the training and continued support going further in terms of human resources or tech support.
I'm happy to take that. If Piwe would like to clarify in terms of pacing, just to make sure I understand your question.
Piwe, feel free to add more detail in the chat, and we're happy to answer.
Yes. So in the meantime, yes, in terms of the pace and the support for training, I think the reason and the motivation behind us applying this hybrid and the blended learning as well as the cascading approach was that once the managers and supervisors are trained and they've gotten a grasp of the actual content and the whole course, they're also able to support our mentor mothers and community health workers. So that's the support that they provide, the training support, even in the blended learning approach. So in the monthly meetings, because our team, the managers and the supervisors have gone through the entire course, they're able to then respond to any questions and facilitate the discussions around the different modules and topics there. So that's the support that is provided. And then in terms of scaling, we plan to use the national CHW training approach. So in South Africa, the training happens, we start with the training of trainers, that is the CHW team leaders and mentors. So we train those who then in turn train the CHWs themselves. And we also have DOH trainers as well that are specifically responsible for training that cater as well. So in terms of training and scaling, we would also envision a stepwise and cascading approach as well, so that there's that continuous support throughout. Yeah. Thank you.
I would say for our case is not much difference. If this was to be scaled at national level, it will still take the whole cascade of training the trainer of trainees, but also getting to understand that some of these trainings have been done. So it is more of sensitization to the digital content so that it's aligned, and then now that can be cascaded to the other levels. And the good bit about this is that in case you do not have resources for training, but the CHW are digitized, you can use the platforms like their monthly reviews or another training to disseminate the content and just showing them how to access as you're waiting to get resources on training on the whole of the ICCM content.
Thanks so much, Helen and Emma. I think the question in the chat about costs and sort of the cost of support and the cost of training are super important. I think we always just sort of articulate that it's that we espouse the priority of making sure that CHWs are well paid and supported and trained, and that's why we do this work. I think to the questions about costs of it, we really think about these training course development programs for creating efficiency of resources. And the digital medic team employs really amazing artists and animators and voiceover artists and translation services as a way to create efficiency of resources so that those training curricula can be disseminated and used by anybody who needs them. So this process of sort of learning about what Emma and her team need or what Hellen and her team need with regard to training, we try to make sure that the response is as efficient as possible, and then support their community health workers to be well trained as we all sort of work together to make sure that they're supported as possible. So I'm really thankful for all the questions and the input, and keen to continue to work together globally so that we can both create efficiency resources to make sure CHWs are trained as well as possible. And please do get in touch with any of us if it is, if you'd like to talk more about things. And just grateful for your engagement and attention, and keen to continue this partnership. Thank you so much, Hellen and Emma, for joining. Thank you, Monika. And thanks to all those who were here today. Look forward to talking further.
Thank you. It was a pleasure.
Thank you indeed.